Morning. Today we have Dr. Georges Benjamin with us. Dr. Benjamin, since 2002, has been the executive director of the American Public Health Association. He's a world-renowned physician with lots of experience in public health. He done some extensive work in Washington, D.C., and he's joining us today to talk a little bit about his career, his background in public health. And so, Dr. Benjamin, welcome to the call, and I'd like for you to give us a little background about yourself and tell us a little bit about how you started in your role in public health and what interested you into the field itself.
Frazier, thank you very much. I'm really glad to be here. You know, I never really thought I'd ever go into medicine. It wasn't even on my radar screen. I went to medical school to get the basic science background to do molecular genetics research. I was particularly interested in research around sickle cell anemia, but fell in love with clinical medicine. And it was the early days also of the specialty of emergency medicine. And I gotta admit, as much as I talk about promotion and prevention, I'm not a primary care kind of guy. You know, I really, frankly, like the blood and guts of emergency medicine and the fast pace of it. So I did internal medicine and then got involved in emergency medicine, again, in the early days of the specialty. And spent 9 years on active duty in the Army, got out, went to the city hospital, and I was at the DC General Hospital as chief of ambulatory care and community medicine for about 2.5 years. When my phone rang, and it was the mayor of Washington, D.C. on the other end of the phone saying, "Have I got a job for you?" And as they say, the rest is history. I was a city health commissioner in D.C. for almost 2 years, and then, you know, new mayor, new job, and went out and practiced emergency medicine for a while. And then the different mayor asked me to come back and run the EMS system in D.C. I did that for almost 10 months. And again, new mayor, new job, then to go back to Maryland, to the newly elected governor of Maryland as a deputy state health officer and then the state health official there. Lots of reasons I didn't go back into clinical medicine. I missed it, but we regulated everything. So I frankly couldn't both practice and be a bureaucrat, unfortunately. So I ended up, took the bureaucratic route and have been in public health ever since.
Outstanding. That's very fascinating. I didn't know until reading your bio that you were in the Army. That's very good background information. I served in the Marine Corps myself. So here at Regis College, we have an online Master Public Health program. And of course, we have a number of students from all over the country, and they are, you know, of course, interested in public health careers. And so when considering a career in public health, can you describe, like, for instance, in the public health specific field, what initially drew you to public health, and how has the American Public Health Association helped you promote what you believe as it relates to public health?
Well, I've always been an administrator throughout my medical career. Literally, right out of my residency, I had some administrative experience. And so administrative medicine, health, public health, particularly at the administrative level, has always fascinated me. I like running big things. I like solving big problems. And what I tell young people to do in public health is, A, first of all, get a good education. You know, that's the first thing. Come as best you can, learn all the skills that you can, and become very competent in the field in which you choose. Also, choose something that you're going to have fun doing. You know, if it's not going to have fun doing, why do it? And then I tell them, you know, you can do anything that you want. The only thing I encourage people to do is, you're going to do kind of really deep, basic science research, you got to do that early. You know, there's very few mid-career ways to get into research. And so if you're going to do research, you think that's on your area of interest, do it early. It's easy to go from research to practice and from practice to research. what other than that, I tell them that, look, everything else is, is an opportunity for you. Also, make a list of all the things you don't like to do. Have a soul searching moment. I don't like to do this. I don't like to do that. I knew early on I did not want to be a managed care medical director. I thought I might want to be a medical director and run big systems, but I just didn't want to, turn people away from healthcare. That just wasn't me. So all the managed care calls I got for jobs, I just put them on the list and said, nope, that's not for me. But I do know that early on I decided that I wanted to, kind of merge my emergency medicine experience with public health. And so I've gotten, to the extent there's an expertise in disasters and terrorism, and particularly biological terrorism, which is of course an easy crosswalk between public health and medicine and kind of emergency preparedness. And so I've spent a lot of time, both reading, consulting, talking to people, engaged, teaching it. And so I saw that as kind of my area, my niche, in the world. That doesn't mean I don't do other things. I'm a still rabid anti-tobacco advocate. And because I'm an ER doc, obviously I care about injury, like firearm injuries and motor vehicle crashes and things like that. But at my very essence, I felt that I needed to have something that I was very good at, that built on all my skills. And it's the disaster, terrorism, emergency preparedness world that kind of rocks my boat the most.
Very, very interesting. Emergency preparedness. That makes me think about a COVID quite a bit with what we're facing today. Let me give you a quote of something you said. I hope that you remember. It may have been some time ago. You said, you know for sure that 80% of what matters healthy inside of you happens outside of your doctor's office. For instance, 80% of what makes you healthy happens outside of your doctor's office. As it relates to the social determinants of health, you also say that generally those are societal goods. What do you mean specifically about that?
Yeah, let me own up to that as a painful revelation. Again, I said I'm an ER doc. I like the blood and gore of emergency departments. And I think it's wonderful and important for us to be able to do the kinds of things that save lives and put people back together when very bad things happen, because bad things do happen in life. But it is true that 80% of what makes you healthy occurs outside the doctor's office. Access to food, access to ability to walk around, being in a safe community, not being exposed to toxic fumes, having water that's safe to drink and food that's safe to eat, having actually access to food that's affordable in your community. Those are the kinds of things that, at the very minimum, help you become healthy or serve as a barrier to you being healthy. So
sure.
If you live in a community which has rundown housing and pestilence and injury risk, and there's no food services in your community, there is an overabundance of alcohol, lots of not against bars, not against restaurants, but lots of liquor stores, just because that's the way the community is zoned, and lack of access to healthcare. Even if you have the insurance card, to get into the system card, the fact that the provider's not in your community, you're less likely going to be healthy. And there's just an enormous amount of evidence that proves that.
Yeah. So, and that brings me to my next question, as it relates to COVID-19 and how it has impacted, particularly communities, low-income communities and communities of color. How do those communities that have those social determinants of health, how do they stay healthy? What are your suggestions for how they can stay healthy at work, healthy, in their home environment? What are your suggestions for how we deal with COVID?
Well, we know that communities where you had to go to work and you couldn't stay at home and telework. We knew that communities that had disproportionate amounts of hypertension, diabetes, we know that, people who didn't have paid sick leave, for example, were much more likely to go to work, much more likely to get infected, much more likely to bring it home with them. So, of course, that means that those were historically communities of color that's disproportionately impacted because we had all those three attributes. And we know that during COVID, that it was very important for you to follow those important prevention tools because you're going to be out and about. This is a disease that you get from other people, generally through the respiratory route. And for that reason, wearing a mask, wash your hands, keeping that 6 feet difference, and not getting out in large crowds dramatically reduce your risk. And then, of course, getting vaccinated when your time comes. All of those things will dramatically improve your ability to survive this terrible tragedy that we have going globally. And then the fact that, if you live in a community, and quite frankly, the challenge was early on, we didn't do adequate testing in communities of color. We did not have adequate access to healthcare. And even though the federal government paid for a lot of, paid for the test, paid for some aspects of the response, when you don't feel well, generally it isn't a visit to the doctor to get your COVID test. The chief complaint you have when you go to the doctor is, doctor, I don't feel well. I've got a sore throat, I've got a headache, I've got a cough, I've had chills. Generally that results in co-payments, deductibles, and if you don't have health insurance, paying 100% out of pocket. So even though the test might have been free, the cost to actually get into the system and be evaluated by the system disproportionately impacted people who didn't have health insurance coverage, didn't have a car, had to get on public transportation. You don't feel well. The last thing you want to take is 2 trains and a bus. Same thing with going and getting your test. We had wonderful drive-through testing. I applaud the drive-through testing system, but they weren't in the hood.
Right. Yeah, that's unfortunate. And I think, even in my state now, the federal government has given millions of dollars toward vaccination sites, but uptake in the minority communities, I see, again, talking about social determinants of health, uptake is not very high. And also there's a uptake problem seemingly with healthcare professionals. What do you think that the reasoning or what's going on? Why is that happening?
Well, there's a good news, bad news story there. So let's talk about the bad news first. The bad news first is that certainly early on, a lot of hesitancy, a lot of concerns about people. They were curious about the vaccine, but not yet confident enough to take it. And concerns about safety and efficacy. So let's deal with those 2 questions. And by the way, it is okay to have questions. So people should not feel threatened when, if you're going to be a vaccinator and someone has questions. That's okay. They're supposed to have questions. And we know that the issue around safety, well, this is a new technology. At least 2 of the 3 vaccines that are available in the United States are new DNA or RNA, mRNA technology. And the third is similar, but it uses a virus to basically get that mRNA in your body. But the point being that we have been spending over 10 years looking at this technology. So this is not something that just came out of the woodwork. People have been working on this kind of a vaccine for many, many, many years. Remember the first SARS outbreak that we had several years ago, that Middle Eastern respiratory syndrome that one gets from camels? Those are coronavirus infections, and they're the same family as this current SARS-2 virus that we have. So people have been trying to make vaccines against that using this technology for years. So what they were able to do is because they had learned so much, particularly the last SARS outbreak we had. In fact, they almost had a vaccine, by the way, for that many years ago. So they were able to jumpstart that process, and the federal government weighed in with the money, because vaccines don't make companies a lot of money. And so they're always very hesitant to go out on new adventures unless they know there's going to be a product that they can sell at the end of the rainbow, and they get some support along the way. And normally that support happens very slowly through NIH research grants. It's a slow crawl. But in this case, the federal government threw a lot of money on the table and promised to buy the product at the end of the day. In fact, they had contracts to buy the product. With that, they were able to rapidly do those research projects. And there was a lot of pressure to make sure that they had people of color in the research cohorts that they did. And there were African-American in particular researchers, and also Latinx researchers involved in the actual research itself, conceiving the projects and doing the research. So with that in mind, these research projects were very different than we've had in the past. So when they looked at the data they delivered very transparently, and it shows that the side effects are very mild, in consistency with most other safe vaccines. So show a shoulder, headache, maybe fever for chills, about 48 hours at most, and then you're fine. We know what this disease looks like for a whole year, and we know what the vaccine looks like for about 8 months now. And it is very clear that this vaccine is safe and much safer than getting the disease. Efficacy, that means how effective is it going to be? Well, vaccines can do two things. Number one, they can prevent you from getting really sick and dying. And the second question is, can they keep you from being infected? Most of the studies looked at the former and not early on at the latter. So they looked and they showed that, yep, very, very effective at death and dying and getting real sick. Over 90% in most cases, 70, 80% in some of the other vaccines that are in the pipeline. So very, very effective. And by the way, the benchmark that the Food and Drug Administration had was that it would protect over half the population, right? So this is way ahead of what even the floor was for acceptability. And then the question is, does it prevent you from getting infected originally and infecting others? And while there's some early studies that show that vaccine probably does protect you from shedding and infecting other people and getting infected, it's not real clear yet. It's not 100% that we understand all the intricacies of that. And so while people are saying it looks good, we're not yet ready to make a call on that. And that's why we're telling people to continue to wear a mask afterwards. First of all, until you're fully vaccinated and until we know the research studies, the results of these new research studies. But I can tell you it's looking good. Now, most people of color were very hesitant to get the vaccine initially. Again, that's the bad news story. The good news story is that that's turned over 180 degrees. As people have seen other people get vaccinated,
sure,
they are much more comfortable. And let me just say, as of this morning, we have over 93 million people in the United States that have been vaccinated, and over 300 million people worldwide. And the general safety and efficacy profile of this vaccine is some of the best we've ever seen.
That's awesome. So this will help when we market. This will help others see this and say, okay, maybe I'll get the vaccine now. People often look to government officials for good health advice. And oftentimes we realize that that's not the case. We need people like Dr. Georges Benjamin to give us good advice, because what you just shared with us is incredible information about. And so these are the questions that people have. They have questions about efficacy. They have questions about, is it safe? And they don't get an opportunity to ask the questions. But that's the crucial point, and it's very important to public health for people to understand that's our role, to educate people so that they can make an informed decision. One of the things that I heard you say, that you were tobacco activists. And so how do you feel, or what is your position on the ban of menthol? And how do you see public health role as it relates to that, as it relates to African Americans, particularly who consume a lot of the menthol related products?
Yeah, we should ban menthol. Menthol is designed specifically to addict communities that preferentially like those those brands like Cool. They're
My dad
designed
smoked
to
Cool.
allow us to for it to be more soothing. So it's not just a chemical adjunct to make to the harsh tobacco utilization more acceptable physically, but it's also marketed for its ability, and it targets communities of color. Now, when I first came on the board at APHA, there was the new big tobacco law that we were trying to get through, and they had all the flavors on there except menthol, pretty much. And we all compromised, not all of us, but many of us compromised, and I was one too, because the law was going through, and we said, okay, what we're going to do is we're going to prove that menthol also needs to be added on. So the big tobacco law that allows FDA to have much more authority to regulate tobacco got passed. And then the idea was to come back with an add-on to prohibit menthol. The studies have been done. It's been shown that it preferentially negatively impacts minorities. And so the FDA must now outlaw menthol as a flavor. And by the way, we're seeing this same battle on flavors occurring with e-cigarettes. Marketing of candied flavored e-cigarettes and bubblegum flavored e-cigarettes. And yeah, as a kid, I love bubblegum. By the way, as an adult, I probably love a little bubblegum as well. But, it's doing exactly the same thing as menthol. It's to entice young people. They use adults as a foil, and we need to ban all these things.
You're right. I believe, again, this is very helpful conversation, because when we talk to our students about public health and we explain to them, the trends, sometimes it's trends, e-cigarettes, major problem in public health. One of the other thing, we're returning back to school. A lot of colleges are going back to school, starting to go back on campus, and CDC recommends some places they're recommending 2 masks, and there are all types of things that are happening. But this is the key. Returning to school and returning to work and returning to college has created an enormous amount of stress. Professors are stressed, students are stressed, and stress is another major mental health, public health issue that is coming up a lot now in the news. How do we, as administrators, as professors and students of public health, deal with stress as a public health issue? You're muted. I think you're still muted. There you go.
Yeah, I think we should acknowledge that it exists, and that's the first thing. Second, we have to recognize that returning to the workplace, because we're not going back to school. We've been in school. We've just been doing it virtually, right? In most cases. So it's going back to do it in a different environment. And we have to recognize those stressors exist. And we have to give people the time and effort to readjust. And we have to ask them up front what tools do they need to readjust. And by the way, in some cases, this will be a less stressful move. For many people, there was a trade-off of work-life balance. In some cases, they got a little bit different work-life balance. But what Zoom and these remote educational opportunities and engagements have done, in many cases, have increased or changed the work-life balance. So I get things from my staff, for example, at very odd hours, usually not during the regular workday, because they're dealing with their kids and helping them go through school. So as their children go back to school and they begin to readjust their lives, we need to understand that there's going to be an adjustment period for everybody. We're not going to just go back all of a sudden, boom, on a particular date, hop in our cars and drive back to work and pretend like everything is going to be normal. We've learned how to work differently from home, how to go to school differently from home. And I think the future is going to be very different. This is a major disruptor. Disruptors can be productive and helpful, or they can be unhelpful and unproductive. And so we're going to have to figure out how we adjust these in our lives. So that means that public health is going to have to, those of you in research, let's study it. Those of us who are on the clinical behavior side of things, let's help people understand those stressors and give them the support that they need. And those of us who run things, we also need to do that. We need to give people the time and effort and understand, because it's people are generally afraid. They're afraid of things that they were never afraid of before. They're afraid to get on the bus.
Mm-hmm.
Not because they're going to get in a bus crash. That's what people used to be worried about, getting on the bus because they might get mugged, or they might fall and injure themselves. Or, these are just things that happen in life when you go out and about, or even driving your car. But no, now they're afraid of touching something and getting infected.
Sure.
And we have to dissuade people of those fears. Those are not fears that they need to have. And we need to do a better job of educating people on the science, what the risks are. And they need to frame this, in my view, as risk reduction. And by the way, we humans aren't very good at it. I jokingly often talk about the fact that I've seen people cut themselves, and they've got a cut that's bleeding pretty moderately, and they put a pressure dressing on it, and the bleeding has really stopped. And then they jump in their car like a bat out of hell without their seatbelt, going to the ER. Where was the real risk, right?
Right.
And I want people to think about that through this COVID. What is the real risk? People have been getting on the bus every day. There's no evidence that people are getting infected. They've been getting on the trains every day. There's no evidence they're getting infected. Flying, at least so far from an infectious control perspective, has been really very safe overall. And and we don't know what it will do when we scale up completely. But right now it seems okay. I'm not encouraging people to hop on planes, by the way, so no one get me wrong. We don't need to follow the CDC guides, et cetera. But I am trying to say that as we think about return to school, return to work, we need to ask ourselves, what are the real risks? What are the things that we in public health, using the science, can encourage people to do to reduce their risk? And then we need to follow.
Sure. And I know we're getting close to the end time, and I just wanted to make one more. So the American Public Health Association, incredible organization, been around for years. I'm actually a member, but also a member of the online group, in the COVID crisis, but also a member of the online group on LinkedIn. Can you just give students and everyone who's going to be able to hear this call a little plug about the American Public Health Association and the resources that you all provide? Because there are still a number of people that don't know about the American Public Health Association, interestingly enough.
Thank you, Frazier. So we are your professional society. We've been around since 1872. We're a 501c3. We provide education, networking, engagement. We have an enormous amount of tools. We have 3 overarching priorities: access to care, eliminating health inequities, and building public health infrastructure. And we have tools for that. We have strong programs around climate change and health, racism and health. We have programs around, we've got over 30 different interest groups in the association, from breastfeeding to environmental health to nursing. We have a community health workers group. So we have just a plethora of things for you. Our big annual meeting this year will be at the end of October. I encourage those of you to come. We believe that we will be able to have a safe face-to-face meeting, but there are 3 ways to participate: face-to-face, online, And then actually there's a small group of a package of our captured materials that one can view later if one chooses. We also have a big policy meeting that we conduct, and this year we'll be doing National Public Health Week, which interestingly enough is the first full week of April. And that Thursday or Friday, we have this Policy Action Institute that'll be looking at health policy for the first time. And we have several administration figures that will be talking with you. We also will have several members of Congress who are kind enough to come on board and talk with us. So, we do a lot of stuff around advocacy, and one of the things we like to think of ourselves as, I think in the conclusion, is that we believe we're the collective voice for public health. I mean, there are many, many things that I cannot convince an individual to do just because I'm me. Particularly around my own family, like most of us, right? But I can get all of you guys to gang up on them. and people are much more likely to listen to a thoughtful group of collective voices, whether it be members of Congress, our elected officials, our communities, and the business community. And so we like to think of ourselves as a group that gives people the right information at the right time to make the right decisions.
Awesome. And again, on behalf of Regis College and our online Master Public Health program, we really thank you for your time today and appreciate all of the great pearls of wisdoms that you've shared. Thank you so much.
Frazier, thank you. I'm glad I could be here.
All right. Thank you.